intestinal nematode and somatic or tissue nematode. Intestinal nematode, again they are either small intestine or large intestine. Small intestine are the major nematodes like Ascaris, hookworm, strongyloides. Hookworm means it could be either ankylostoma or Necator. Large intestine you have Enterobius and Trichuris. Somatic nematodes examples are all filarial nematodes, then Trichinella spinalis and Dracunculus. Dracunculus. You can also classify the nematodes based on what will be produced after fertilization. Accordingly, they are classified as oviparous, viviparous and ovoviviparous. Oviparous, viviparous, after fertilization directly larva is produced. There is no egg stage at all in viviparous. All somatic nematodes are example of viviparous. Oviparous, after fertilization egg will be produced. Eggs are converted to larva very soon, mainly in the intestine itself. Whereas ovoviviparous eggs will be produced, one second, there is a mistake. Oviparous eggs will be produced, eggs will be converted to larva after long time, mainly in the environment, soil. Whereas ovoviviparous eggs are produced, they will become larva very soon in the GIT itself. All somatic nematodes are viviparous, all intestinal nematodes are oviparous except strongyloides, which is an example of ovoviviparous. So, which is the diagnostic form for strongyloides? Egg or larva? Larva. Others? Egg. So, let us discuss the life cycle. Life cycle of T we will discuss together. Cycle we will discuss. T stands for Trichuris, Enterobius and Ascaris. All these three why are discussing together, because the mode of transmission is oral, infective form is same, that is embryonated egg. So, when you take embryonated egg in the GIT, egg will become larva, larva gradually will become adult, adults are male and female, they undergo cross fertilization to produce egg. And for Trichuris and Ascaris, eggs are of course initially unembryonated, eggs are initially immature, that is unembryonated. And for Trichuris and Ascaris, the unembryonated eggs are only diagnostic form. They will become embryonated egg only in the environment. What is remaining? Enterobius. For Enterobius, the unembryonated egg will become embryonated egg in the GIT itself. So, what is released? Embryonated. Actually, embryonated egg will not be released in feces, they are usually present in the perianal skin. Perianal swabs you have to take. because they will be crawling in the perianal region. So, you will take a perianal swabs where you will get embryonated egg as the diagnostic form. And because embryonated egg is a diagnostic form, embryonated egg is also the infective form for enterobius. That is the reason why enterobius there is one more mode of transmission, that is autoinfection. Autoinfection is seen in enterobius because the diagnostic form and the infective form is same. So, by the contaminated fingers the same form can be again be passed. So, this is a common life cycle for all three, and in Ascaris one step is extra. They say that in Ascaris the larva penetrate the GIT. In Ascaris one step is extra. The larva penetrate the GIT and they through the GI vessel they reach lungs, and from lungs by the swallowing of sputum again they come back. From lungs by the swallowing of sputum again they come back to GIT. So, the pulmonary phase is extra for Ascaris, and that is why you have low flux pneumonia in Ascaris. Fine. Then let us discuss little bit individual. Trichuris, also called as weepworm, and the main clinical why it is called as weepworm, because the adult worm is whip shaped. Adult female worm is whip shaped, having a handle and a whip, and because it is whip shaped it can cause large intestinal erosion, and the large intestinal erosion lead to the main clinical feature is trichuris dysentery. Dysentery will be produced. Diagnostic form, unembryonated egg, and the description is like this: barrel shaped, having two mucus plug, and of course bile stained, and initially they are unembryonated egg which are released in feces. Okay. Enterobius is also called as pinworm or threadworm. They are thread set, very small structure, and this adult female of Enterobius, it crawls in the perianal region, especially in the night time, that leads to nocturnal pruritus ani, and the specimen of choice is perianal swab, either by a cellophane tap or by specialized swab called as NIH swab. NIH, that is National Institute of Health swab, is a specialized swab designed to collect perianal swab for Enterobius, which is a diagnostic form. Diagnostic form is embryonated egg, and the description is it is plano-convex, having a larva inside, and it is bile non-stained. Plano-convex, it is embryonated. Embryonated means what? Having a larva inside, and don't forget it is bile non-stained. One side is plain, one side is convex, hence it is called as plano-convex. Ascaris, also called as roundworm, and Ascaris of course is one of the longer worm, one of the longest worm infecting man, and it is so long that of course apart from the other GI symptom, non-specific GI symptom, because of the length it can twist and can cause intestinal obstruction, sometimes even intersusception. All these are specific complications seen in Ascaris. And don't forget, it has a pulmonary phase, yes or no? Pulmonary phase can cause Loeffler's pneumonia, which is a diagnostic form. Ascaris, the diagnostic form is unembryonated egg. The unembryonated egg of Ascaris is of two types, fertilized, unfertilized. Why this fertilized, unfertilized word we use only for Ascaris? The thing is, Ascaris is one of the longest worms. Other worms are not that long, they are very small. So Ascaris female worm is so long that it will have lakhs of egg inside, and all the eggs not necessarily will be fertilizing with the male partner. So there is every chance that many eggs without fertilizing they may be released in feces. That usually do not happen with others. Others usually fertilized egg only will be released. Ascaris, there is two kind of egg, fertilized egg will be released also, unfertilized egg also will be released. So fertilized egg is, the description of fertilized egg is round to oval, and it has got a very thick albumin coat. Round to oval and thick albumin coat. Okay, round to oval and it has a very thick albumin coat. And it floats on saturated salt solution. Unfertilized egg is rectangular and elongated, and the albumin coat is very thin. The albumin coat is very thin and it does not float on saturated salt solution. F for F, fertilized egg floats, unfertilized egg does not float on saturated salt solution. Okay, so this is all about Ascaris. Let us now discuss about the other two important intestinal nematode, that is Strongyloides and hookworm. Why to discuss Strongyloides and hookworm together is, Strongyloides and hookworm, the infective form is L3 larva, L3 larva or filariform larva. Mode of transmission is skin penetration. So when the L3 larva penetrates the skin, comes to GIT, inside GIT L3 larva will become adult, adult will be differentiated to, at least for hookworm, adult will be differentiated to adult male and female. They undergo cross fertilization to produce eggs. Eggs are initially unembryonated, and the unembryonated eggs are diagnostic form for hookworm. And this unembryonated egg in the environment will become embryonated egg. Embryonated egg will hatch out to form L1, that will become L2 and finally will become L3, and L3 is the what? Infective form. In contrast, Strongyloides what happens is strongyloides in human intestine, they say that only adult female will be there. Adult males, they do not exist in human intestine, only adult females will be there. So if there is only female, then there is no fertilization. There is no fertilization, there is no egg. No, fertilization is not there, but strongyloides has a power of producing egg without fertilization also by a asexual reproduction called as parthenogenesis. Parthenogenesis, asexual reproduction called as parthenogenesis, and this, because of that, eggs are produced. That means what? Eggs are the diagnostic form or not? No. Strongyloides is example of ovovivi or ovovivi. So if it is ovoviviparous, that means eggs will become soon larva inside the human intestine, and L1 is the diagnostic form. L1 is called as rhabdidiform larva. L1 is called as rhabdidiform larva, and they say that this L1 in the environment will become L2 and L3, then L3 is the infective form. This is called as direct environmental cycle. There is an indirect environmental cycle also, in which they say that L1 will become L2, L3, then adult male and female, they undergo fertilization to produce egg. Egg will hatch out to become L1, then L2, then L3. This is called as indirect environmental cycle. So only in the indirect cycle males are there, otherwise strongyloides males are the most useless living structures of the world. They are the most neglected. Okay, so that's all. So that's all is a life cycle, or something else is there? Something else is still there. They say that strongyloides autoinfection is seen. How autoinfection is seen? They say that L1, which is a diagnostic form, when they are found in small intestine, I mean in the large intestine, they themselves can become L2 and L3 in the intestine itself. If L1 will become L2 and L3 in the intestine itself, then L3 being the infective form, it can cause endogenous autoinfection by reverse peristalsis. It can cause endogenous autoinfection by reverse peristalsis. If that happens, then in no matter of time you will have a huge larval load. They say that by reverse peristalsis L3 will be formed, which will multiply to make a to release a huge larval load. Such a huge larval load can penetrate GIT and goes to various organs to cause an infection called as hyperinfection syndrome or disseminated strongyloidiasis. Hyperinfection syndrome or disseminated strongyloidiasis, and mainly CNS is affected. And this particular syndrome is common in HIV and HTLV1 infected people. Hyperinfection syndrome is common in HIV and HTLV1 infected people. So this is all about the life cycle of strongyloidiasis and hookworm. And hookworm, they sometimes ask how to diagnose the egg. Hookworm will produce a unembryonated egg, which is described as oval, bile non-stained, and initially the segmented ovum, the ovum is segmented. Segmented ovum. Segmented ovum. Okay. And regarding the clinical manifestation, hookworm, it enters through skin penetration. So at skin penetration site you will have local lesion like ground itch and serpentine ulcer. Whereas in GI, of course, iron deficiency anemia, because it sucks blood from the intestine, as well as iron deficiency anemia, as well as other GI manifestation will be there. Non-specific manifestation also will be there, but iron deficiency anemia is the specific manifestation. Fine. So this is all about hookworm and strongyloidiasis. Then filarial nematode. Filarial nematode examples, yes, Wuchereria, Bancrofti, Brugia malai and Brugia timori, then Loa loa, Onchocerca volvulus and Manzanella streptocerca, Manzanella. So these are the various filarial nematodes. They say that filarial nematodes, they have a specific habitat. They say that the microfilaria microfilaria means it is the L1 form. The L1 form of the parasite is called as a microfilaria. The microfilaria comes to the blood only at a particular period of time. So this is called as habitat or periodicity of the parasite. Wuchereria, Bancrofti and Brugia malai are nocturnal in habitat. They are nocturnal in habitat. Loa loa nocturnal means they will come to the blood in the night time. Loa loa is diurnal, that is daytime it will come to the blood. Onchocerca and Manzanella, they are non-periodic. Regarding the vector, Wuchereria, Bancrofti, the routine vector is Culex, which is nocturnal, whereas the strains that are transmitted by Aedes, those strains are sub-periodic in habitat. They say that Wuchereria, Bancrofti can be transmitted by Culex, Aedes as well as Anopheles. All three can transmit Wuchereria, Bancrofti. Most common is of course Culex fatigans is most common, but the Aedes infected strains, the habitat is sub-periodic. Sub-periodic means they will come to the peripheral blood in late evening, and Aedes infected strains are endemic in Andamans. Endemic in Andamans. Okay. Brugia malai is transmitted by Manzanella and Anopheles. Most commonly Manzanella followed by Anopheles. not Manzanella, Mansonia, transmitted by the vector, the mosquito Mansonia, followed by Anopheles. Brugia timori is transmitted by a species of Anopheles called as Anopheles barbarostis, and this timori is endemic only in the Timori island of Indonesia. The Timori island is located in Indonesia, only in that particular island this is seen. Onchocerca volvulus, the vector is black fly. Black flies or the genus Simulium. Manzanella Mbbs is the common name, whereas the generic name is Culicoides. Okay, so this is the vectors what you need to remember, very very important table. And they say that the microfilaria of some of them will have a sheath outer covering. If this is a microfilaria, then some of them will have a outer covering. It is covered by a sheath, not all, but some of them there is a outer sheath. So peripheral sheath will be present is Wucheria, Brugia and Loa Loa. Wucheria, Brugia and Loa Loa, the microfilaria is sheath microfilaria, whereas Onchocerca and Manzanella are, they do not have sheath. Okay, so this is how the difference. Next is how the life cycle occurs. Life cycle, they say that L3 form or the filariform larva is the infective form, transmitted by mosquito bite. So the L3 form larva will be deposited on skin. Through skin it will enter into local lymphatics, and through local lymphatics it will go to the regional lymph node. Regional lymph node. So when they go to lymph node, inside the lymph node the L3 larva will become adult male and female. They undergo fertilization to produce no egg. They are viviparous. No, viviparous means directly L1 will be produced. L1 are also called as microfilaria. So this L1, otherwise it will be residing in the lymphatics. Most of the part of the day it will be residing in the lymphatics, except at certain part it will come to the peripheral blood. Peripheral blood, it will come only based upon the periodicity of the parasite. Nocturnal parasites will come in the daytime, night time. Diurnal parasites will come in the daytime. Subperiodic strains will come to the peripheral blood in late evening. So this is all about the periodicity, and they say that the pathogenic form is nothing but adult female, not the microfilaria. Adult females are the pathogenic form. They multiply in the lymph node, and that leads to lymph node obstruction, lymphadenitis, lymphangitis. So these are the various pathological features. This occurs because of the adult female, not because of microfilaria. And disease can be classified into 4 stages: endemic, normal, these are the normal individual in endemic area; asymptomatic filariasis. There is no symptom, but they will have microfilaria will be positive in blood. Then acute filariasis, they are symptomatic patient plus microfilaria will be positive. Symptomatic like fever, as I told you, edema, lymphedema, then lymphangitis, lymphadenitis, dermatolymphangaitis, skin infection will be there. All these are various features of acute filariasis, and please remember microfilaria will be positive in blood. Followed by chronic filariasis. Chronic filariasis occurs long after, they say that 10 to 20 years later the acute filariasis, and here the pathogenesis is due to a severe obstruction. Severe obstruction, and the severe obstruction leads to the lymphatic vessels will be seriously obstructed, occluded. The occlusion of the lymphatic vessel lead to various manifestations like chyluria, hydrocele, elephantiasis, granuloma of the female breast. So all these are specific manifestation of chronic filariasis. Lymphatic varices, one more is lymphatic varices. And please remember, chronic filariasis also microfilaria will be mostly, it will be negative in blood. Microfilaria will be mostly, it will be negative in blood. So in contrast to lymphatic filariasis, there is one more form of filariasis called as classical filariasis. I mean, lymphatic filariasis is otherwise called as classical filariasis. One more variety is there which is called as occult filariasis. What is the difference? Lymphatic filariasis, the pathogenic form is adult female, whereas the diagnostic form is microfilaria in blood. Most of the pathology takes place in lymphatics. In contrast, occult filariasis is a condition, it is a hypersensitive reaction to microfilaria antigen. The pathogenesis is due to a hypersensitive reaction to microfilarial antigen. In contrast, the microfilaria will be absent in blood. Organ will be affected, will be most common organ will be lung, where it is called as tropical pulmonary eosinophilia. And here diagnosis is done by hyper IgE and eosinophilia. These two are the diagnostic feature. These two are the diagnostic feature. Fine. So now lab diagnosis. Lab diagnosis, again you can go for a peripheral blood microscopy. Based upon the timing, based upon the habitat, the blood is collected. For example, nocturnal parasite, blood is collected between 10 p.m. to 4 a.m. Subperiodic strains, the blood is collected between 8 p.m. to 10 p.m. Diurnal will be daytime, maybe 2 to 6 p.m. But how you can avoid this timing? You want to collect at your own time, not at the time when the parasite will come. Then you can do a test called as DEC provocation test. You have to provocate the parasite to come to the blood. DEC provocation test is give a tablet of DEC to the patient, the microfilaria will dance and will come to the blood within half an hour. So this is called as DEC provocation test. This can be done to collect the blood even during the daytime. So once you collect the blood, if you do a peripheral blood smear, then it is important to differentiate between microfilaria of Wuchereria bancrofti and Brugia malai. They say that Wuchereria bancrofti the microfilaria, of course it is sheath, it will have a outer sheath. Outer sheath will be there and inside the nucleus will be there. They say that inside nucleus, the inside of the microfilaria, it is filled with nucleus. So the identifying feature is the tail end. The tail end is pointed. You can see the tail end is pointed and it is free of nuclei. Whereas Brugia malai is also sheathed, both are sheathed, but the tail end is blunt. Will be like this, the tail end is blunt and the nucleus are extended till the tail tip. Tail end is blunt with nuclei extended till the tail tip. Okay. So this is how you can differentiate. If the parasite density is less, in blood, then you can follow centrifuge techniques, that is concentration, blood concentration is done, or even QBC also is followed, quantitative Buffy coat examination, what you do for malaria parasite, that also can be followed here. Fine. So this is all about the peripheral blood microscopy. Next is antibody detection. Various methods are available like ELISA, immunofluorescence assay, etc. But problem is antibodies are cross reactive and they cannot differentiate between recent and past infection. In contrast, antigen detection is very popular. Antigen detection is specific as well as it can differentiate between recent and past. Antigens can be detected even during daytime. There are two antigen detection methods are available. One is ELISA, detecting AD12 antigen, and one more ELISA method is available which detects OG4C3 antigen. So these are the three antigen, two antigen detection methods are available. PCR also you can do. PCR is highly sensitive. X-ray and other imaging methods can be done. Ultrasound and X-ray. Ultrasound, if you do, then you can see the filarial densine in scrotum. Filarial dance sign in scrotum. Okay. Next is drug of choice. They say that DEC is a drug of choice, diethyl carbamazine. In India, DEC plus albendazole based regimens are given, whereas African countries DEC plus ivermectin based regimens are given. And in this context I want to tell that DEC act on both microfilaria and adult, whereas ivermectin acts only on microfilaria. Ivermectin acts only on microfilaria. Then the other parasites, I mean other filarial parasites, like for example Brugia. Brugia, can you tell me what is the vector? Brugia, the vector is Mansonia followed by Anopheles. Okay. Mostly the strains are nocturnal. Rarely subperiodic strains are there, and they are transmitted from monkeys. They are zoonotic strains transmitted from monkeys by Mansonia vector. And don't forget that for the survival of the Mansonia, Pistia plants are important. Pistia plants are important for the survival of Mansonia vector. So in the Phalariasis eradication program, removal of Pistia plant is one of the strategy. Removal of Pistia plant is one of the strategy, because they are important for the survival of Mansonia vector. Okay, then clinically Brugia malai infection is almost same as Wucheria bancrofti infection. Only difference is here only leg below the knee is involved. Okay, the elephantiasis occurs only below the knee. There is no genital involvement, that is, there is no hydrocele. Okay, so acute adenolymphangitis is the most common manifestation. Acute adenolymphangitis is the most common manifestation. Okay, so this is all about Brugia malai. And Brugia timori, I have already told, it is endemic in the Timori island of Indonesia. It is the only place where it is seen. A bit about Loa Loa and Onchocerca. Loa Loa is the agent of Calabar swelling. Calabar swelling. Whereas Onchocerca volvulus is endemic in Africa, and it causes various manifestations like dermatitis, leopard skin. All these are cutaneous manifestations. Nodule called as onchocercoma. Apart from that, ocular manifestations, skin manifestation will be all this. Ocular manifestation is, it causes river blindness. And they say that the lymph nodes will be hanging, and this particular sign is called as hanging groin. The lymph node will be hanging from the groin region, I mean it will be hang from the groin region, and this particular sign is called as hanging groin. Okay, diagnosis is of course detection of microfilaria in skin specimen, and here remember the skin specimens are collected by a method what we follow for leprosy, that is slit skin smear. Slit skin smear is the method to collect the skin specimen what you follow in leprosy, and microfilaria can be seen. And apart from that, the skin test called as Mazzotti's skin test, or which is also called as DC patch test, the other name. Don't forget the drug of choice is ivermectin. Africa, so ivermectin. Okay, so that finishes parasitology.